In this video, we will look at the causes and effects of congestive heart failure. Congestive heart failure is a clinical syndrome where the heart is unable to pump enough blood at a rate sufficient to meet the metabolic demands of the body. There are two types of failure. One is low output failure. This is due to a poor functioning heart. There is also high output failure. Here, the heart function is fine. However, the metabolic demand on the body is too high. Two examples of high metabolic demand states would be pregnancy and hyperthyroidism. Throughout this unit, we will be using two terms, and you need to be aware of what these terms mean in order to understand what is happening with congestive heart failure. The first is preload. This refers to the amount of blood in the left ventricle during the cardiac filling phase. The other is afterload. This is the amount of force that the left ventricle works against in order to pump the blood around the body. There are four basic consequences of congestive heart failure. The first of these is congestion. This is the backup of blood in the vessels upstream from the heart, because the heart cannot maintain a forward flow of blood. This will lead to hypertension and edema in the congested tissues. A second consequence is the activation of circulatory compensation mechanisms in order to maintain blood flow. The third consequence is a decrease in cardiac output. This will cause systemic hypoxia, weakness, and fatigue. And finally, the last consequence is possible death. This occurs when the cardiac output is unable to meet the demands of the major organ systems. There are various possible causes of congestive heart failure. The first of these is myocardial weakness. Here, the heart is unable to pump enough nutrients in order to support life. This might be due to atherosclerosis. Atherosclerosis will weaken the myocardium due to the ischemia. As the atherosclerosis progresses, the hypoxic injury and necrosis of the myocardial fibers will also increase. Eventually, these will be replaced by fibrous connective tissue, which are much weaker than the normal myocardium. Myocardial weakness may also be due to coronary artery thrombosis. This will reduce the blood flow and damages the myocardium, resulting in ischemia. It may also be due to myocarditis. This is an infection of the myocardium. It could be due to cardiomyopathies. This is an enlargement of the muscle with resultant poor performance. And finally, it could be due to coronary vasospasms. This is a sudden arterial constriction with a decrease in perfusion. A second cause of congestive heart failure is restriction to pumping. Here, the heart is unable to cope with its preload due to the physical factors that restrict pumping, and as a result, end up decreasing cardiac output. These physical factors, one might be a valve defect. One type of valve defect would be stenosis or narrowing. This provides too much resistance and results in left ventricular strain. Another valve defect are incompetent valves. Here, the valves do not close tightly and will allow backflow. Another physical factor could be internal obstruction. These would interfere with the free flow of blood through the heart. Examples of an internal obstruction might include a congenital malformation of the heart, a thrombosis, or the presence of a tumor. Dysrhythmias are another physical factor. Dysrhythmias occur when various conditions interfere with the cardiac conduction system. This ends up causing either an abnormal rate or an abnormal rhythm of the heart. This may be due to ischemia, to infarction, or to an electrolyte imbalance. And a final physical factor may be pericarditis. This would be an infection of the pericardium that results in fibrin deposition or adhesions that restrict the pumping. You will also get the development of pericardial effusion. When this happens, it will produce an external pressure that will compromise the filling. The last possible cause of congestive heart failure is an increased afterload. With consistent high physical demand, the strain ends up overwhelming the heart. This will lead to a decrease in stroke volume and a decrease in contractility. Some high physical demands that would cause this: one is systemic hypertension. This creates high vascular resistance, which causes a need for more pumping pressure in order to overcome this resistance. Maybe due to valve disease or congenital defects. We have already discussed this. And finally, it could be due to pulmonary hypertension. This would be increased pressure within the pulmonary vasculature. This will cause more resistance against which the right ventricle must work. This flowchart summarizes the three possible causes of congestive heart failure: atherosclerosis, thrombosis, coronary vasospasms, and cardiomyopathies all result in myocardial weakness, causing congestive heart failure. Valve defects, an internal cardiac obstruction, dysrhythmia, or pericarditis all lead to pumping restrictions. And finally, cor pulmonale, systemic hypertension, or congenital defects all result in an increased afterload. Very briefly, want to mention the high output failure states. With high output failure, these represent an increased demand state in the body that will put excess strain on the cardiac muscle. This will ultimately lead to exhaustion and heart failure, especially when there is a pre-existing congestive heart failure. These high demand states may be due to chronic anemia. With chronic anemia, this will cause an increase in heart rate over time in an attempt to provide more oxygen to the body. Another demand state is thyrotoxicosis. This is high thyroid output with an increased metabolism and an increased need for an extraordinary blood supply to meet the demand. And finally, pregnancy. When one is pregnant, you have an increase in blood volume as well as an increased metabolic demand. We are next going to look at the pathogenesis, in other words, how the disease develops, as well as the clinical presentation and symptoms that would be experienced with congestive heart failure. The following example will use a mitral valve stenosis in order to illustrate the pathogenesis. Mitral valve stenosis would be a narrowing or a problem with the mitral valve. Often, mitral valve stenosis is the result of fibrosis and calcification of the valves. This will prevent adequate filling of the left ventricle, causing a decrease in stroke volume, decrease in cardiac output, and eventually fatigue and weakness. Upstream from the valve, more blood will end up remaining in the left atrium. This will cause left atrial hypertrophy as a result. The blood will then back up into the lungs. This will result in pulmonary congestion and hypertension. As a result of this congestion and hypertension, fluid will begin to accumulate, resulting in pulmonary edema. This can be heard as rales in the lungs upon examination. The lungs will also become stiff and less elastic. Because of the fluid that is collecting in the alveoli, there will be a decreased surface area for oxygen diffusion. This will lead to airway obstruction and poor tissue oxygenation. One can also see dyspnea. Dyspnea is a difficulty in breathing due to the accumulation of fluid and the decreased elasticity of the lung tissue. Orthopnea is a special form of dyspnea that occurs when one is lying down. When one is in a reclining position, this will favor the movement of blood and fluid from the legs and the abdomen back toward the heart. This will then cause increased fluid in the lungs. This can be relieved by elevating the head and the shoulders. There is also paroxysmal nocturnal dyspnea. This is orthopnea while one is sleeping. Unfortunately, this form of dyspnea is not relieved by elevating the head. This increased pulmonary hypertension that is experienced will also predispose the person to pneumonia. The increased fluid in the lungs favor the growth of bacteria. With further progression, you will begin to see a backup in blood into the right heart. This will cause an increased right ventricular preload and an increase in afterload due to the higher resistance in the pulmonary vasculature. This will lead to right ventricular hypertrophy, which will then cause blood to back up in the right atrium, and as a result, you will see right atrial hypertrophy. This hypertrophy is a compensatory change in order to help to try and increase the strength as well as the stroke volume. Unfortunately, it doesn't do this and instead results in cardiomegaly. Cardiomegaly is an enlarged heart that is typical of a chronically failing heart. The term cor pulmonale is a general term for right heart enlargement. This increased right heart resistance will then lead to systemic venous congestion. As a result, you will begin to see superficial vein swelling. The jugular veins will become distended. You will also see dependent edema. There will be increased capillary permeability in the extremities. This will allow fluid to escape into the soft tissues. This fluid will then follow the path of gravity and begin to collect at the low points of the body, especially the feet and the ankles. The systemic venous congestion will also cause an increased back pressure into highly vascularized organs, especially the liver and the spleen. You will see hepatomegaly. This is an engorged liver due to the inability of the hepatic vein to drain into the inferior vena cava as a result of this increased pressure. Splenomegaly is the result of severely increased hepatic portal system pressure. This will lead to congestion of the spleen. This is typically seen in advanced congestive heart failure. This flow chart will summarize all of the pathogenesis and the clinical signs that we just discussed using mitral valve stenosis as the example. Now, the body does have various compensatory mechanisms that come into play under normal conditions to attempt to compensate for a drop in cardiac output or the change in tissue permeability. The problem, though, is with congestive heart failure, it actually overcompensates, and this can cause congestive heart failure to become even worse. One normal compensatory mechanism occurs when more blood ends up being left behind in the left ventricle. When this happens, it causes an increased stretch to the myocardial fibers. This will result in a more forceful contraction with the next beat of the heart in order to increase the stroke volume and ensure that the entire volume in that ventricle is pumped out. Go back to Starling's law that we talked about earlier. This is the basis behind Starling's law. However, in congestive heart failure, this chronic stretching that occurs over time makes the muscles thinner and less elastic. As a result, it is less able to mount an increase in this contractile force. This is known as myocardial dilation. Another normal compensatory mechanism occurs with an increased afterload. This will lead to hypertrophy of the cardiac cells, causing them to have more strength and thickness. However, in congestive heart failure, what we see instead is cardiomegaly, and this will cause a decreased efficiency over time. Another normal compensatory mechanism would be an increase in sympathetic nerve stimulation. Under normal conditions, what this does is it would cause an increase in catecholamine release, such as norepinephrine. This would cause an increase in heart rate. It would also cause vasoconstriction in an attempt to maintain systemic blood pressure. However, in the case of congestive heart failure, this increased heart rate over time leads to less time for the left ventricle to fill, causing a decreased preload. This ends up adding even more stress to the heart. The catecholamines, when they cause an increase in blood pressure, this results in an increased afterload and more pressure on the heart. Another normal compensatory mechanism would be to stimulate the renin-angiotensin system. What this does is it will cause the production of angiotensin II. Angiotensin II is a very potent vasoconstrictor, and it also results in the release of aldosterone. Remember, aldosterone release will cause an increase in both sodium and water reabsorption. What this will do will be to increase the blood volume and increase the afterload. However, in congestive heart failure, this higher plasma volume will lead to a further increase in congestion, and the increase in vasoconstriction will lead to an even higher afterload, and this will end up further complicating the left ventricular cardiomegaly. A last mechanism would be the release of atrial natriuretic factor. This is a hormone produced by the atria in response to an increase in heart rate. It acts by suppressing renin and antidiuretic hormone in order to help decrease plasma volume and prevent an increase in afterload. However, in congestive heart failure, one is unable to counter the antagonistic effects of the enhanced renin secretion that is typically seen with congestive heart failure. This flow chart summarizes the basic compensations that can be seen and also how they exacerbate congestive heart failure. Finally, we will look at various treatments for congestive heart failure. There are some non-pharmacologic treatments that attempt to eliminate the cause of congestive heart failure. A big one is controlling diet. Here, one would want to control both salt and fluid consumption. Exercise is very important. This would involve supervised rehabilitation as well as cardiac conditioning. Valve replacement or repair may be called for, as well as bypass surgery, angioplasty, and heart transplant. There are also various pharmacological means that help to strengthen the myocardium and decrease the afterload. One of these pharmacological agents are chronotrophs. These act by altering the heart rate. If an agent is said to have a positive chronotropic effect, it will increase the heart rate. If it has a negative effect, it acts by decreasing the heart rate. An example of a chronotroph are the beta blockers. There are beta 2 receptors found in the cardiac muscle, and these are stimulated by the sympathetic nervous system. Beta blockers block the catecholamines, and this will decrease the heart rate and contractility, which will lower the blood pressure, slow the contraction time, and allow more filling of the left ventricle for an improved stroke volume. The problem, though, is that beta 2 receptors are also found in lung tissue. So one must take care, especially when treating people with asthma or any other respiratory problems. One common side effect that people experience when taking beta blockers is a persistent cough, because the drugs are affecting and binding to the beta receptors in the lungs. Another class of drugs are the inotrophs. They work by affecting the contractility of the heart. A positive inotropic effect would cause an increase in contractility, while a negative inotropic effect would cause a decrease in contractility. An example of an inotroph is digitalis. This also goes by digoxin, digitoxin, and cardiac glycosides. This is the most widely used positive inotropic drug. It increases intracellular calcium for better muscle contraction, and it also allows for a more forceful contraction at a lower degree of myocardial distension, which would result in less strain. The response would be an increased cardiac output and arterial blood pressure. This will result in better tissue perfusion, better venous return, less sympathetic response with vasodilation, and a decrease in heart rate. One can also use diuretics. These work by decreasing the plasma volume. They work at the renotubular level to prevent the reabsorption of sodium and water. This will lead to an increased urinary output, which ultimately decreases plasma volume, creating less workload on the heart. The problem, though, with diuretics is that they also result in electrolyte loss, which can cause arrhythmias, and they will also lower the blood pressure, which will then stimulate the renin-angiotensin system. There are also antiarrhythmic drugs. These help to regulate the heart rate and rhythm in order to provide a more constant, controlled cardiac output. Another class of drugs are the vasodilators. These work by relaxing the smooth muscles in the arterioles in order to reduce the afterload, and they also relax the smooth muscle in the coronary arteries to increase myocardial blood flow. They act to open up the coronary arteries to provide more oxygen to the cardiac muscle. One example of a vasodilator are the nitrates or nitroglycerin. This allows pooling of blood in order to reduce venous return, stroke volume, and cardiac output to decrease the oxygen demand on the heart. This is usually used in acute care. There are also calcium channel blockers. These inhibit the movement of calcium into the myocardial tissue and vascular smooth muscle. This will reduce vasoconstriction, decrease the afterload, and provide more oxygen to the cardiac muscle. The last group of drugs are the angiotensin-converting enzyme inhibitors, also known as ACE inhibitors. These prevent the conversion of angiotensin 1 to angiotensin 2. Remember, angiotensin 2 is a potent vasoconstrictor. ACE inhibitors work by inhibiting this vasoconstriction, and it will also inhibit the release of aldosterone. These help to shut down the sympathetic compensatory responses. ACE inhibitors are the only drugs shown to actually improve congestive heart failure. They improve the survival rate and exercise capacity in patients. They decrease hospitalizations and decrease morbidity by preventing the progression of the disease. And they also decrease mortality by 15 to 25%.